Okay, I would like to now introduce Professor Lisa Stamp from the University of Otago in Christchurch, and she's going to talk to us about stamping out gout.
That's a terrible title. I think I had the same problem as Hayley. I was struggling to think of a title, and that was a really bad one. Anyway, I'd just like to start with this whakatauki, the leader at the front and the workers behind the scenes, because I think that really typifies my research career. I'm an academic clinician, so I work half-time at Te Whataora Waitaha, the Christchurch Hospital, seeing patients. I see a lot of patients with gout. I'm a rheumatologist, so I treat all forms of arthritis. And I have a very supportive clinical team who allow me to fulfill my academic career. And I have an amazing team who actually do all the work while I stand up and present all the results. And they always say to me they hate me going away because I dream up a new idea to come back with to give them more work. So I think this really represents the team's efforts, not just my efforts. And so I am going to talk about gout. It's one of my favourite conditions in the clinic because it's one of the very few conditions that actually, if we manage it well, we can make a real difference. And there's not many forms of arthritis that you can do that with. Most of them, we can manage the symptoms, but gout, we can effectively take the problem away if we get the treatment right. Now, the thing about gout is it's been around from a very long, for as long as Hayley's been digging up bones, and before that, there was evidence of gout in dinosaurs. And this quote comes from a book, The Study of British Genius, which I always think is quite an interesting one. No pathological condition which occurs so often in such extreme forms and of men of such preeminent intellectual ability that it is impossible not to regard it as having a real association with such ability. I refer to gout. And this has been really the story of gout, that it's related to food and wine and, all sorts of things. And there's been a number of really famous people throughout time who've had gout. It's been called the disease of kings for that reason. Coming here as a newly elected fellow, I was reading a little bit about the society and about Rutherford as one of the first fellows. I did try to find out, but I couldn't find even any evidence that he actually had gout. But as you'll see, there are a number of really important people in history there who have. As it's already been alluded to, New Zealand is a great place to do research about gout. It has been called the gout capital of the world, and that's really because the prevalence is so high in our Māori and Pasifika people. And you can see this here, that the prevalence in Māori men over 65 years is 35%, in non-Māori men is 17%. And overall, we have very high rates, if you look at all age groups, by ethnicity, about 13% of Māori and 70% of non-Māori, non-Pasifika have gout. So this is a really big health issue. The other big issue for gout in New Zealand is that Māori and Pasifika people have much worse gout. They get it earlier, the disease is more severe, and as Hayley alluded to, they have a lot of comorbidities. So they have a lot of diabetes, high blood pressure, heart disease and kidney disease. So this isn't just something that occurs on its own. And you can see that this, people think of gout as being, you get a sore joint and then it goes away and everything will be fine. But in actual fact, you can see here from this picture that this can be a very, very disfiguring disease. The lumps that you can see over the joints there, they were called tophi. They're collections of uric acid under the skin. And you can imagine how difficult it must be to do something with a hand that's got these gouty lumps on it. And equally, if you look at this image down here, this is some new radiology imaging. All those red dots are little gout crystals that we can now actually see with our imaging techniques. And you can just imagine how painful it must be to have all these little gouty crystals sitting inside your joints. So gout's caused by a buildup of uric acid. We all make uric acid naturally as our cells break down. We do take in foods and liquids, i.e. alcohol mainly, that are broken down to uric acid. And I like to think of it as a bit like a bathtub. We either make endogenous purines that comes from the natural body turnover. We can get the purines from what we eat and drink. They fill up the bath and the body. And then the kidneys, where the majority of the uric acid is excreted. And if the plug gets blocked for some reason, then you don't get rid of the uric acid as much, and so it builds up. And when it builds up to a certain level, then you get the uric acid crystals forming. They can deposit in and around joints, and it's the body's reaction to that crystal that causes the painful flare of gout. People say it's as bad as childbirth, having an attack of gout. At least that's what my female patients tell me. The male patients, I don't think they quite believe that, but they do say it's the most painful thing they've ever experienced in their life. Now, we do have a number of drugs that we can use, and there are drugs that stop the body producing uric acid. These are the ones at the top here. You can obviously restrict what you eat and drink to stop the body making uric acid, and there are some drugs that work at the level of the kidney to help you pee out uric acid. But overall, this is a particularly badly treated condition, despite the fact that it is eminently treatable. Keep going the wrong way. So a lot of the work that I have done over the last 20 or so years that I've been back in New Zealand has really been about how we can manage gout better. And allopurinol is a drug that's been around since the 1960s. It's cheap as chips, it's 10 cents a tablet, and it's the first-line treatment for gout worldwide. But really, it's very poorly used. The mainstay of treatment is to reduce the uric acid levels in the blood. It's a bit like it's basic chemistry. If you've got a cup of sugar and you put a teaspoon of water in it, you can't dissolve the sugar, but if you flip it around, you'll be able to dissolve the sugar away, and when the sugar's dissolved away, like the uric acid crystals are, you don't have the impetus for the flare. We know that if we can get the blood uric acid levels down to an appropriate level, then actually people will get better. They'll stop having attacks of gout, and those lumpy bits will disappear over time. And we should get to the point where actually people don't ever have a gout attack at all. And we've recently shown that with some evidence that we've looked at from combining data from two clinical trials, one that was done here in New Zealand and one that was done in the UK. I think the other thing is that New Zealand is, I think it's fair to say, a bit of a powerhouse in gout research. My main collaborator, Professor Delbeth in Auckland, we've worked for a number of years on clinical trials. I see Dr. Nairi Kerse here, who had the joy, I'm not sure if it was joy, or maybe joy, of being on the Data Safety Monitoring Committee for our first clinical trial that we undertook. I think it just about did the Data Safety Monitoring Committee in, like it did us. But we can change clinical practice worldwide here in New Zealand with clinical trial work. This wasn't from a clinical trial, but it was data that showed that we need to be careful about the dose we start at. The reason people get frightened of using this particular medication, allopurinol, is because it can be associated with a very severe allergic reaction. And about 30% of people who get that allergic reaction will die. And that's not a good outcome when you're treating anything, but not for treating gout either. So we really looked, it took us 20 years, going back over 20 years worth of admissions from people who got this allergic reaction to show that it really was related to the starting dose. And on the basis of that research, both the American College of Rheumatology and the European League of Rheumatology changed their guidance on how this medicine should be used. We then looked at whether we can safely increase the dose of allopurinol, because people have always been worried if we give too much of this medicine, we're going to cause this bad reaction and people are going to have a bad outcome, and that's not good. But the other problem is if you don't treat sufficiently, then you'll be giving somebody a medication without them potentially having any benefit. So we really looked at whether you could increase the dose of this medication to give clinical benefit and it would still be safe. And we did show that if we systematically increased the dose, we could get the clinical benefit, and there was no increase in side effects from that strategy. Now, the thing people always want to know about is, well, what do I eat and drink if I've got gout? Everybody wants to know about that. And this is really a myth that we're trying to undo. Gout is not, you don't get gout because of what you eat and drink. You might cause a gout flare, an acute attack of gout, by eating and drinking in excess some things, but ultimately your diet is not a main contributor. But there have been all sorts of figures like this about what you should and shouldn't have. Alcohol's always at the top because we do know that alcohol will precipitate a gout flare, particularly beer. It's full of purines. All the traditional things that you'd think of, red meats, shellfish, a lot of kaimoana, which is obviously problematic for our Māori population who enjoy that. And so we've looked at a number of different things that there have been myths about what you should and shouldn't eat. And so we've looked at sugar. Haley mentioned this. We know that sugar is bad if you've got gout. Fructose in particular can increase your serum urate and cause you to have gout. There was a phase for a while that people should have tart cherry juice from some particular cherries called Montserrito cherries. And this was based on some internet studies that showed that if you ate more of these cherries, then you were less likely to have gout. But when we systematically looked at that, we didn't show that it had any effect on gout or on your uric acid. So that's kind of gone out of favour now, although eating cherries is always nice. There's been work from the group looking at the relationships between coffee intake and gout, and coffee's actually probably okay, which is just as well. And then there was another big drive a few years ago about taking supplemental vitamin C, that if we all took, or if people with gout took a lot of vitamin C, that this would help cure their gout and stop them from having to take other medications for it. And again, we showed that that didn't work. And all of these have influenced international guidelines on how we should manage gout. So with that, I'm going to finish. Just like to acknowledge the research team. That was the team when I first started. My two clinical colleagues, two clinical nurses, and myself and my one research nurse. We've grown a little bit since then, but not much. And again, just to emphasise that my success should not be bestowed upon me alone, as it's not an individual success, that this is the success of a collective. Thank you very much.
What's your comment on, their school of thought, particularly your first article in anemia, Chinese philosophy. Basically, I was the person who is seeking the consultant. I'm just close, still below the threshold. The thought is you should balance your lifestyle, your food, everything, and you should watch out the level by periodical exam, then you'll be fine. So that's the thought, it's not something you have to worry about. You just have to pay attention to lifestyle, food, everything. What's your comment on that?
Yeah, so what I routinely tell the people I see in gout and in the trials regards diet is we really want to destigmatise this, and I think there's been a lot of stigma about gout. It's what you eat, it's what you drink, this is all your fault, you've got this disease. And we're really trying to move away from that and destigmatise this condition. I think my advice is you should be eating a healthy diet, and you need to maintain a healthy body weight, because we know that a high body weight is also is associated with gout. If there is a particular food that you can eat that triggers a gout flare, so, go out with your buddies and have half a dozen beers and a steak, and then next morning you wake up and you've got gout, then I would moderate that intake. The carrot is, if you actually take the tablets and get your uric acid levels down to the right level, you will be able to go out and have that beer and steak with your mates and not get gout. So, it's a really individual thing. Some people don't have particular foods that trigger it. I had one patient that told me he couldn't eat anything that was red. Any red food was out for him. So, yeah.
The mutations prevalent in Pacific peoples, and I'm a victim of gout, but I'm very Scottish in
So most of the mutations we see target the renal transporters, so the transporters in the kidneys that are responsible for excreting the uric acid, and that's where the main genetic things are, and it just alters the rate at which urate can be excreted.
So it's not a target for differential pharmacology because people have got differential.
Well, that's a really interesting question, and yes, it could be. So there's one particular medication. So you could envisage that if you had a gene that reduced your ability to excrete uric acid in your urine, that if you gave a drug that caused you to increase the uric acid, that it might work more effectively than a drug that was going to stop your body producing it. So there is that thought. There are currently no really good funded drugs that would do that. So benzbromarone, which we had, was taken off the market. Lesinurad, which did that, caused a whole lot of kidney problems, and so came off the market very quickly. So at the moment, we're not stratifying by genetic type, but there are some other genes also that are influenced in the way the drugs are handled, so particularly allopurinol, where you know there are some genes that make it more or less likely to be effective, but we're not at the stage of prescribing based on genetic type at present. No. Interestingly, Taiwan is the only country in the world that suggests you treat what we call asymptomatic. So somebody who's got a high uric acid level without ever having gout. So they recommend that you treat that with allopurinol. They're the only country in the world. They did also show that people who were treated with allopurinol for asymptomatic high blood uric acid levels were more likely to have that really bad allergic reaction. And also, I think the other thing to remember is that, if people have got a high uric acid, not everybody with a high uric acid level actually gets gout. So over 5 years, only about 20% of people are going to get gout. So at the moment, we don't routinely do anything to prevent it. What we do advocate is if people have got families, is that they don't just tablet share, that if they get what they think is gout, they seek medical attention themselves so they can be treated appropriately, because there's a lot of tablet sharing that goes on.
So maybe I'll tie a little bit of the last two together. Diabetes as well. When you think about the idea of genotype and all the genetic systems you track on with specific people, so therefore however many 10,000 years or more of motion, it seems clear that the idea that this is a genetic disease, something that one might almost be born with, rather than the disease of, we'll call it sedentary disease, we're lazy, but, that it would, being a genetic disease would change the discussion from one of, get off your ass to one of, we need to treat a condition that you have. And it seems clear that that's failed so far. What do you think it would take to change?
Oh, look, I think changing gout management has been uniformly very, very difficult. I think that changing attitudes, as you know, is very difficult. And this disease, as I said, has been around for, the concept that this disease is a disease of kings and of what you eat and drink is so highly ingrained even now. I think it is very hard to change that. You just look at the language around a lot of advertising around gout things. So I don't know how we change it. We start one patient at a time by educating the patient in front of us that this isn't their problem, that this is, they've not inflicted it on themselves. We educate them about the genetic influence, and then we hope that they take that out and spread that to their whānau and family and friends. We do a lot about educating general practice. I mean, 90% of gout is managed in general practice, but it's, medicine is actually slow to be, academic medicine results are slow to translate into clinical practice, and it's going to take some time for that to happen. And the New Zealand health system's got much bigger problems at the moment than how we manage gout.